Good morning. It's Wednesday, December the 8th. This is Open Mics with Dr. Stites. I'm Dr. Steve Stites, Chief Medical Officer here at the University of Kansas Health System. We're broadcasting live with you from the Dulles Simons Family Studio. Thank you for joining us this morning on Facebook and YouTube. Today, we're talking to a VIS, a very important scientist who has saved millions of lives with his COVID vaccine breakthrough. He's also one of Time's most influential people of 2021. He's also a true Jayhawk. We are pleased to be joined by Dr. Barney Graham, the former Deputy Director of the Vaccine Research Center at the National Institute of Health. We'll talk about how he helped make the discovery and what he is learning about the new Omicron variant. We are also delighted to welcome Dr. Robert Simari, Executive Vice Chancellor at KU Medical Center, also a true Jayhawk and one of my good friends. It is just a pleasure to have you back in this studio with us, man. It's been too long.
It's nice to be here.
It's too long. This is awesome.
The whole thing is taking too long.
Yeah, the whole thing is taking, and I don't think it's done yet.
Yeah, it's not done.
We got to get it done. All right, so make sure to get your questions sent in to us on YouTube, Facebook, and the Medical News Network. You'll find links to those right here on your screen. Dr. Dana Hawkinson, our Medical Director, Infection Prevention and Control, will be joining shortly to go over our COVID numbers. They're not going down yet, because they're still on the rise. We still see more cases. And we heard from our chief medical officers of the community yesterday, especially from the Northland, the rapid rise of that curve doesn't strike good feelings for any of us. Before we start our conversation, though, let's see if we have any reporter questions on the line. All right, I don't hear any. Before we get to community questions in just a bit, but first, Jess has something you'd like us all to see, Jess. And Jess, I think I'm going to feel really good about some cool Star Trek stuff coming up, huh?
You are, but we're going to make you wait the whole. You're going to have to work for it.
I do. I can't. We can't do it right now. We have to wait for the whole show.
No, you have to work for it, but hang tight.
Fine.
We'll get to that in just a moment.
Fine.
Good morning to you, Dr. Stites, and of course our entire fantastic panel today. Many people, as we know, still ask and wonder exactly how the COVID-19 mRNA vaccine works. So this morning, we have a video that might help you better understand exactly what's going on in there when we do get this vaccine put into our body. Dr. Hawkinson found this video from the Vaccine Makers Project. Take a look.
Hey, and news break. There's no microchips in this video, in the vaccine.
Like many viruses, it uses a protein on its surface to attach to and enter our cells. Antibodies that fit onto this protein can block the virus from attaching. Coronavirus mRNA vaccines teach our immune system to make these antibodies. How do mRNA vaccines do that? mRNA is a genetic material that instructs our cells to produce proteins. The mRNA in the vaccine is wrapped in a layer of fat particles that protect it and help it get taken up by specialized cells of the immune system called dendritic cells. Once inside these cells, the mRNA does not enter the cell's nucleus or interact with DNA, but remains in the cytoplasm with other mRNA molecules, waiting to create the enzymes our body needs. When ribosomes read the vaccine mRNA, pieces of the viral surface protein are made. These pieces are then displayed on the surface of the dendritic cell. The dendritic cell travels to a nearby lymph node, where it presents the surface proteins to other cells of the immune system. Some of these cells, called helper T cells, train B cells how to make antibodies that will fit perfectly onto the surface protein of the virus. Other cells stimulated by the protein pieces, called cytotoxic T cells, can kill virus-infected cells. Now, when the coronavirus tries to infect us, our immune system is ready, immediately recognizing, neutralizing, and destroying it before we ever even have a chance to become sick.
So Dr. Stites, I'm going to turn it over to you for this conversation this morning, but would certainly love to hear from you and the other doctors on the panel what you think of this video. Is it accurate? Help us understand.
Well, let's turn to Dr. Barney Graham about that very question. Dr. Graham, what's your thought about that video? Oh, you got to unmute, Dr. Graham.
Yeah, first of all, good morning, and it's my pleasure to be with you all today, virtually back in Kansas for a few minutes. This video, I think, is very well done, and it does demonstrate the mechanical processes for how the RNA goes into the cell and how it's used as a blueprint or a template for the cell to make this spike protein and initiate the immune response. And I think that is the most important part, that it is a small, simple piece of RNA that's rapidly degraded. The lipid nanoparticle that protects it is also rapidly degraded. So within a few hours after vaccination, the vaccine is actually gone, and what's left is some of the protein that it has encoded for. And that protein is what generates our immune responses, and that protein then is there for a few days, and then it's gone. So this is one of the simplest vaccines I think that's ever been made.
So I didn't see any microchips in that vaccine that are trying to tell our government what we're doing or try to control us. Is that accurate?
Right. I wouldn't know how to do that, and that is one of the stories that's come out of this. I don't know if it's been confused with the term nanoparticle. Maybe that's what triggered some of these concerns, but a nanoparticle simply means that the size of the particle can be measured in nanometers. It's only a few nanometers in diameter, and so that's why it's called a nanoparticle.
And it doesn't change your DNA, the vaccines. It doesn't do anything to
It doesn't
DNA.
change your DNA. In fact, the mRNA doesn't ever make it into the nucleus where your DNA is. And so some of the concerns about fertility or changing your DNA, those kind of things really just aren't true. The RNA goes into the cytoplasm, it's degraded after that. It never makes it into the nucleus where your chromosomes are, which is where your DNA is.
And just to remember, viruses, when they invade us, they can mess with our DNA. They can get in and kind of take apart our machinery and make errors. Is that right?
Yes, some viruses do. Some viruses stay entirely in the cytoplasm, but many viruses do affect things going on in the nucleus. And so if you're worried about changes in your DNA, I'd be a lot more concerned about getting infected than I would about getting the vaccine.
Right. The vaccine may actually even help you protect your DNA, not invade your DNA. What'd you think of the video, Dr. Simari?
Well, I sat here thinking about sort of full circle. So 1968, I'm in the backseat of my parents' car watching The Fantastic Voyage. Do you remember the movie Fantastic Voyage?
I remember that.
The
Injected
scientists
into your cells?
The scientists were shrunk down.
Down.
Raquel Welch was one of the scientists, to be noted, but nonetheless, were shrunk down and injected into the bloodstream to find a bullet, or I can't remember.
Something. Well, they did a lot of things.
I remember the tricuspid valve was part of the problem. But the video was great. It really got you into the machinery of what works. So I thought it was exceedingly effective. Barney, I might ask, the idea that the mRNA that was chosen was based upon sequence from that was obtained very early in the process. But one of your main contributions was to understand what mRNA was important to present the spike protein in its right form to remain the most antigenic or the most effective. How did that research develop? Was that something that happened quickly? You've been working on that for a while, or what was the duration of that sort of process?
Yes, well, there's a 1-year story, and there's a 3-year story, and there's several other stories in between, but it really goes back 40 years. Since we've been working on HIV vaccine development, and even though we don't have an HIV vaccine yet, the efforts that have been put into that and the investments have created technologies that have really entirely changed our concept of vaccinology, especially over these last 10 or 15 years. And so understanding how the shape of a protein, how the detailed atomic levels, surfaces and things of a protein affect its ability to be a good vaccine was something we discovered for a different virus, respiratory syncytial virus, back in 2012, 2013. And we learned that that was the F protein. It's very similar and works the same way as the spike protein on coronavirus. And we found that if we identified the shape and as it started and then held the shape together with some protein engineering, basically gluing things together from the inside so the outside doesn't change, that it all of a sudden turned from a vaccine that didn't work very well to this protein now being something that boosted your immunity at 20-fold or more. And so that process was then applied to another envelope viruses, which was coronavirus. And over those last 8 years, working on mostly the MERS coronavirus, which was emerging, breaking out in the Middle East, during that same time we were working on the RSV, that led to understanding the shape and the structure of the spike protein of a human beta coronavirus. And we learned how to stabilize it. We learned how to deliver it by mRNA, and we already knew in the end of 2019 that that would protect mice from a lethal challenge from the MERS coronavirus. So we knew all those things. We knew about the structure. We knew how to make the right protein. We knew how to deliver it. We knew that it worked. We had academic partners and industry partners, and we basically were at the right place at the right time and knew what to do and had the resources to do it.
Yeah, it's a really big deal. So to give you an idea of the impact Dr. Graham has had on keeping all of us safe during the pandemic, take a look at this chart. It finds more than 3 million people are fully vaccinated against COVID-19 in Missouri, or roughly 51% of the population, 55% of roughly 1.6 million in Kansas. Now, just to say, that's not great. Yeah. Right? We need to be in the 80 or 90% range, but that's not where we are. So Dr. Graham has had an amazing impact with this. And since you helped create these things, tell us a little bit about what we're learning now around the Omicron variant and the activity of vaccines with Omicron. A lot of news is breaking around that. So, and even this morning, Pfizer BioNTech making announcements about it. Help us know where we are with relative to Omicron.
These viruses, especially RNA-based viruses like the coronavirus, we know change. We knew from the beginning that this virus would evolve. And what that means is it changes nucleotides. It doesn't replicate itself perfectly. And each of those changes give it a chance to make a slightly different protein. And the protein is still 1,273 amino acids long, but it may have a slightly different charge or chemistry or slightly different shape. And that's what determines whether antibodies will recognize that protein. So over time, because we didn't get the whole world vaccinated in 3 months, which would have stopped everything, the virus has continued to grow and evolve in people. Every time it infects a new person, it has a chance to change into something that could eventually escape our immunity. And so this has been happening all the way through. People have heard about variants of interest, variants of concern. And so WHO has given each of these, there's an infinite number of these, but WHO has given them Greek letters when it becomes a variant of interest and then a variant of concern. And so as people hear about beta and delta and now Omicron, it's just really the evolution of the virus. And I have a model here. I don't know if you can see it very well, but let me get it into view. But this is what the spike protein looks like at about a 10 million times magnification. And so we can see these kind of details in the protein. And for instance, if that little loop moves over here or just moves a slight amount, that antibody that used to see that little loop won't bind it anymore. And so when the amino acids that affect the surface contours of this protein change, it makes our antibodies that we have less effective. But it doesn't change everything. Even the Omicron virus is only changed around 50 of those amino acids out of 1,273. And there's many places that the antibodies can still bind. And we know that you still have some cross protection. So I think the Omicron virus is the natural evolution of this thing as it tries to survive and keep being transmissible. What we don't know is, what really matters is how much disease is the Omicron virus going to cause. So the vaccine may not be quite as dramatically effective as it was against the matched viruses or even against Delta. But if it can slow the virus down, if the virus itself is not as virulent, and meaning it doesn't cause quite as much disease, then I think that we're still in reasonably good shape. We're in much better shape than we were 2 years ago.
Dr. Simari, I want to. So you're the leader of the University of Kansas Medical Center, and we talk in this program a lot about faith, hope, and science, and I know you're a man of all three of those things. Talk to us though about how inspiring is it to you to see someone like Dr. Graham, a Jayhawk, helping develop science that's saving the world. I mean, talk to us about the impact of research in science.
Yeah, I think the pandemic has been the most important example in our history about how academics and science and medicine can do incredibly important things. What's more important than saving the world? Right. I mean, so one of the things that's really come together during this is these partnerships and collegial relationships and worldwide. I mean, we get data from South Africa the minute it's published. A sequence that was published in South Africa was spread around the world immediately. Barney, you got the sequence from China, hours after it was performed of the original coronavirus? I mean, these are collegial relationships that would have never happened otherwise. And really, it's science, medicine that's leading the way. I've never been more proud to be a physician or to be in education than I am right now. I mean, regardless of what we're doing for the supply chain on the front lines, which is probably one of the most important things we're doing right now, this is an incredibly important time to be a physician and a scientist, but it's not easy, right? That's the other thing that we got to realize is it's not easy, and people have been struggling through this process.
You bet. And you wonder, you have to ask yourself, how many lives would have been lost if there was no science in this pandemic?
Yeah.
If science had not delivered this vaccination, where would we be? We've had 750,000 or thereabouts lives lost in the United States. 1 in every 420 people in the U.S. has now died of COVID-19. By the way, that's a stunning number. How much worse would that be if vaccines had not been there to help change that tide?
Yeah, and I guess Barney, everybody asks, are we 50% through this, 80% through this? Is there an answer that we can provide to people that's based upon science and an understanding?
Well, as I said, we're part of the way through it. I don't think we can say when it's going to finally end. I think that's what's wearing everyone out. It's what's demoralizing to our healthcare providers who've been on the front lines and who many of whom have lost their lives trying to take care of sick people. But we are getting to a place, I think, where we at least have tools. We have vaccines for prevention. We have monoclonal antibodies for therapy, and now we have antivirals to treat people as well. So we have tools. We know how the virus works. We can stay ahead of it. And I think one of the things we're learning here is that if we don't have solutions globally, that it will come back around to us. And we need to develop systems globally that will allow the world to be immunized more quickly. We could have had generalized immunity in just a few months instead of it's going to take 3 or 4 years. We could have prevented the emergence of all these variants. And I think that's one of the things we're learning here. So we are making progress. It's not clear when it's going to end. If you look at 1918 flu epidemic, it killed estimated 50 to 100 million people on Earth during that time when the world's population was much, much smaller. And it took 3 or 4 years to kind of burn itself out. And that was at a time before we knew that it was caused by influenza. That whole epidemic was lived through by people who didn't even know what was causing it. And T cells weren't invented yet, and antibodies weren't understood very well yet. So we survived that pandemic with a lot of loss and a lot of death, but we did get through it. We are going to get through this, but the question is how much of the suffering and pain and loss can we avoid?
So let me ask you, as you look at the pandemic and you read about Omicron, I mean, I think there's this fear now that Omicron is going to sweep the globe and take all these lives. I keep saying we can't call it the oh my gosh variant. We just have to say it for what it is. Preliminary data coming out of South Africa suggests that maybe it's not as severe. Is it too early to really say that? Well, what's your sense of how Omicron is going to compare to Delta?
Well, it's too early for me to say that, but that's my hope, because eventually what this virus will do, it will evolve into a virus that will cause seasonal, annual outbreaks in the wintertime, and it'll mostly be in children, and it won't be very severe. It'll be mostly upper airway cold. We have 4 other circulating coronaviruses that have been with us for between decades and hundreds of years. The first one is thought to enter the human population about 800 years ago. So we have 4 coronaviruses that circulate every wintertime. They infect some people. They usually don't cause severe disease. And eventually this virus will become like that. It will adapt to growing better and better in the upper airway, so it can be better and better transmitted and keep replicating. That's how it's selected. Every time a new infection occurs, it gives viruses a new chance for selection. So when people say they don't need to be vaccinated, it won't make me sick, it won't cause me any problems, but they fail to understand the consequences of one more person having virus replication. That changes the whole context of the virus.
So why do viruses exist? Why do they kill people? So it seems to me to be odd that viruses kill people, since that means they kill the host and they can't reproduce then. I know it's an existential question, but I think for our audience, it's one of those things that it's kind of this puzzle, right?
Well, we have been intimately connected to viruses throughout history, and if you look at the human genome itself, I mean, people worry about having their DNA changed, but it may be that viruses have been connected to some of our evolution, in fact. And so you look at the genome of humans, I think around 4% of it may have come from endogenous retroviruses. And those are viruses that can get into the nucleus, that can get into your DNA. And that amount of our DNA and chromosomes is actually more than what we use for encoding the 25,000 proteins that we use to make us human. So we have always existed with viruses in a way that sometimes causes illness, sometimes doesn't cause illness.
So Dr. Fauci wrote that you, in time, that you had saved millions of lives. How does that make you feel?
Well, it's hard to get my head around that, because the problem still isn't over. And even though I retired from the federal service, I'm still very involved in it. And knowing that 5 million people have died, or a little over 5 million people have died of this virus, and that about 30% of our population doesn't really believe in it or doesn't want to take the help that is available for this virus, that less than 10% of people on the African continent have been vaccinated so far. It just feels like we have such a long way to go. And we're finally getting our children immunized. I think that's going to make it safer for us to have people going back to school and get normal life started up again. But it feels like there's just a long way to go. So it's hard to know how to feel about that.
Barney, you had said that this global distribution of vaccine and a global approach was going to be one of the things that you were going to be thinking about more in retirement. What are the main drawbacks to getting the African continent? Is it supply chain? Is it what are the limitations, or are they not desiring to be vaccinated?
No, it's historical, and there's many aspects of this system that needs to be developed in order to get this done. But I think that new technologies, especially the ability to do chemical synthesis. So the mRNA is not made in what we call a bioreactor. It doesn't require large vats of cell culture to make this vaccine. And so without the need for a large campus full of bioreactors and having the ability to chemically synthesize something like this with a relatively small footprint of equipment and the capability of making small batches, hopefully relatively cost effectively, it means that there may be an opportunity now to change low and middle income country access to vaccine manufacturing, much in the same way that the cell phone has changed the ability of in Africa to communicate. And so you basically skipped over 2 generations of technology. They don't have much cable in the ground like we do everywhere here, and they just went straight to cell phones. And I think that going straight to chemical synthesis, there's no lack of interest and there's no lack of capability. There is a need for infrastructure development, not just for making the vaccine itself, but for all the supply chain and things needed. There's a need for workforce development, people everywhere from the technicians who work on the equipment to the scientists and people who develop and then make the vaccine. There's a lot to be done, but there's no lack of interest and no lack of will and no lack of capability. It's really just, I think, a matter of transferring some of this newer technology concepts and trying to skip a couple generations of manufacturing approaches and get everyone caught up. And the value of that is that they then can take care of their own regional problems, their own regional diseases that may not have commercial interest, but have a lot of public health interest for them. And they can then solve those problems before they become global problems, before it turns into the next pandemic. Even HIV at one point was just a regional zoonotic emerging infectious disease that just wasn't recognized before it became a global pandemic. So
Such a big deal.
That will solve those problems, and it would also allow them to have the surge capacity during these crises to help vaccinate their own people.
Yeah, so important. Well, listen, we're going to get to some community questions. I know they're out there, but before we do, we're welcoming Dr. Dana Hawkinson to the studio. Hawkeye, how are we doing today?
Hi. Sorry, I forgot I was on the show. I was just so intrigued. I think everybody should show this show and what Dr. Graham is saying to everybody they know. I think his answers have been really good, spot on, and I think helpful for everybody in the community and around the nation as far as this show gets fed out.
And like you, he's the Jayhawk.
He is. That's always good.
Yeah. And they play Missouri this weekend.
I know.
It's going to be a tough game. We lost to UMKC. I'm not sure what that score in Ken Lawrence is going to be like.
Yeah, it'll be tough for Missouri.
It's going to be tough.
Yep.
Okay.
So today, we've been talking about increasing cases and hospitalizations. We are continuing to see that trend in the hospital, unfortunately. 39 active infections with 13 patients in the ICU, 9 of those on the ventilator, and 24 in that recovery period. A total of 63, but you know what, Steve? 3 of those 39 active infections are fully vaccinated. And we know that one of those fully vaccinated people is here for a completely different reason, was found on a typical admission screen and is asymptomatic right now for COVID.
So the reality is that's less than 10%, and which is actually lower than what we've been seeing, which just emphasizes once again, we are in the midst of a pandemic of the unvaccinated, because if you've been vaccinated, you're going to be safe. And what we're hearing today and what we're hearing is the news breaks is that it looks like current vaccination, Omicron, you'll still be protected from severe hospitalization and death, which has always been the real point of vaccination to keep us safe. And so I think this is, again, a pivotal moment. If you want to stay safe, if Thanksgiving's coming up, or Thanksgiving's past, this Christmas is coming up, the holidays coming up, you want to be with family and friends, Hanukkah's coming, you've got to stay safe. And the only way to truly stay safe is to follow the rules of infection prevention and control, which keep you safe up until this moment. They travel with you everywhere you go. Jess, what are the questions we have out there?
Yes. Okay. Well, as you can imagine, we have a lot of questions, and I'm going to start out with a question from a friend of mine. Her name is Angela, and I know she's watching right now. And I told her to watch today because Dr. Graham was going to be on and help her with this question. And I think she represents a lot of parents like myself who have kids that are eligible to get vaccinated. She is not an anti-vaxxer. Her and her husband are both vaccinated. She really wants to get her kids vaccinated. But I think because of a lot of misinformation out there and all the politics surrounding it, the social media, she's struggling. And so Dr. Graham, her question, and it dawned on me, I think there are a lot of people who have this one about fertility. She's concerned about her future grandchildren. And not just that we've done the research and that it's safe, but could you help her, Dr. Graham, understand what's going on inside the body with the vaccine when you get it, that is okay, that it's safe to get it, and that it does not hurt kids' fertility? Could you just dive into that and help her feel confident so we can get her kids vaccinated?
Okay. Well, first of all, mRNA is made in every living cell on Earth. Trees, fungus, fishes, everything. Every cell that's living is making mRNA. It is the element, it's the chemical that allows the cell to make proteins, which is the building block of all life. And so mRNA is in all of our cells all the time anyway. And if you get infected with the virus, you're going to have way more mRNA being made from the virus, not just from the spike protein, but from all its other proteins that will be present in the body. And so what the vaccine does is deliver a single strand of mRNA that encodes. It's the blueprint for basically making the structure. It's like the blueprint for a house, making the house. Well, the mRNA is the blueprint for the protein that makes the cell, or makes the spike protein. And so that mRNA goes into the cytoplasm, the outside part of the cell. It is degraded very quickly. The mRNA is gone within a matter of hours. The protein it makes is gone within a matter of days. The mRNA never comes in contact with your DNA. And let me just say, even if it did, which it doesn't, the amount of RNA that you're exposed to from the virus during an infection is thousands or millions of times more than the amount of RNA you're exposed to during this simple vaccination. So if you're really worried about this viral RNA changing your DNA, then I would definitely go get vaccinated. I have had my 2 daughters vaccinated. One of them is still planning to have children. All of our 8 grandchildren have been vaccinated, and some of them, about half of them, are girls. And if I thought there was any chance that there could be any long-standing problem with any of them, I would have never allowed that to happen. And so I don't know how to convince you with my words, but I can tell you, if you study the biology of RNA, that you will start to understand why this problem is not a concern. It's a concern that's been produced through misinformation campaigns for reasons I don't really totally understand, but it is not going to be a problem for your fertility.
That's so, we appreciate that. So, Dr. Graham, just to jump in for a second, how soon do you think before 6 months to 5 years we're going to have the opportunity to be vaccinated?
I'm not sure. One of the reasons it's taken longer to immunize our children is that they don't become as sick. But I think people have underestimated how severe the disease is in children. And in a typical influenza year, even the bad year of 2009, about 200 children died of influenza. Well, there's been more than 700 children, young people under 17 years of age, who died of coronavirus. This is not a trivial disease, even in children. Most children will recover, but some children will die, and some children will have unusual disease syndromes and have things that may last for a very long time that limits them. And we don't know what it does to future lung function. We don't know if people who have severe infection as a child, and will it change their lung development? We won't know that for several decades. But I would encourage all of us to protect our children as much as possible, and getting the vaccine down into these younger and younger age groups, I think will eventually happen. I don't know the timeline for that. The critical objective right now, I think, is to immunize school-age children and all these susceptible adults so that we can get this transmission chain broken.
I mean, historically with children, we've been able to really eliminate polio as a major threat to young children, measles, mumps, rubella, all through the science of vaccination. It is striking to me that for whatever reason, people want to make up stuff. We call it the MUNs, the made-up news network. The MUNs are out there trying to say these weird things about vaccination for reasons that I'm not really clear on. It's just odd to me, and so much hesitancy, so much misinformation, and yet the history of vaccination just demonstrates how important it is if you really want to have healthy children, healthy lives. So, Jess?
Isaac wants to know, why aren't efforts being focused on making vaccines to go after the regions of the virus that don't change between mutations? Or is that even possible?
That's a great question. Dr. Graham?
Well, the spike protein is the major surface feature of the virus, and so it is the main target of most vaccines, and it is only representing about 1/6 of or a little over 1/10 of the total virus in terms of protein content, but it is the best target. And there are groups, including our group, who've spent a lot of time trying to understand how to generate cross-reactive antibodies, and antibodies that would cross not only to other versions of the SARS-CoV-2, but even to other beta coronaviruses. And so there are sites on the virus that are relatively unchanged, even between different strains of coronavirus. And that is part of the strategy for making what are called pan-coronavirus vaccines. That is a big initiative within NIAID, or Dr. Fauci's Institute, the National Institute of Allergy and Infectious Diseases. So that is a strategy. That's one of the main strategies we're using to make better influenza vaccines as well. So the technology we have, and having structural definition of all those sites, and being able to easily isolate new human monoclonal antibodies that bind each of those individual sites, gives us the possibility of doing that. And so some of that is being done. And so, yeah, it is a good question, and it's one of the strategies going forward.
Dr. Hawkinson, you had something.
And I think I would agree with Dr. Graham, and just to kind of add on to that, there are benefits of the spike protein, and there are regions in the spike protein that change very little. Those are what we have been referring to as those conserved regions. And we do see immunity because of that, and that is partially, or a great deal, of the T-cell immunity that we garner from these just mRNA spike vaccines as well. And so I think it is a very good question, but we do see that. We do see that in our immunity that's garnered by the vaccines. is some of those regions that are unchanged or change very infrequently, we do get immunity to those right now with the current vaccines as well. And I would defer to Dr. Graham if he has anything to add to that.
Let me just talk to Dr. Murphy. So, Rob, I listen to this conversation, and you hear the science, and it just makes sense to us. But we're in the world of science. We're also in the state of Kansas, where there is a lot of vaccine hesitancy. What are you hearing? What are some of the reasons? And because to some degree, it feels this is going to feel too strong. But it's a little bit of an attack on science, and that's what we do. We're not trying to mislead the world. Help me grapple with that a little bit.
Well, if we had been here 3 years ago and said, well, what percent of the population is going to be vaccine hesitant, we would have said, what, 10, 15, 20% maybe at most, and a lot of it tied up into misinformation around autism and other issues. And we might have been okay with that 10 or 15% because half of them might have gotten infected. We would have gotten the other 80, 90% vaccinated in that quick period that Dr. Graham mentioned. We would have been okay. So what's that next layer, right? So what's the next 20, 30, up to 40%? It's the political, social challenges of our society currently, right? And a lot of it is being not one to be told what to do, and a lot of mistrust about people trying to tell people what to do. And so it's so very complicated. But here's a situation when we have a native Kansan, guy that grew up in the area on a farm, did this, who was the ultimate, should be the ultimate person to be trusted, and yet here we are.
Yeah,
Steve, this is the conundrum, and I think I heard Dr. Collins say the other day, Dr. Graham, that really understanding the sociology and the psychology about this process probably needs a lot more investigation along to understand what these challenges have been. That's a whole other area of science.
Yeah, that is it.
We can overcome
like
the lack of science with more science, not less science.
I think that is as good a way of I've heard anybody say it. So thank you, because there is. We've done the science of vaccinology, but we haven't necessarily gotten into the science of sociology around this. Dr. Graham, thoughts about that?
Well, it is a conundrum. What I've said I'm going to spend my time on is community education so that we can improve people's understanding of biology in general, and maybe that will change some of the sociology. A lot of this requires trust, and if people have lost trust in institutions, sometimes for misinformation, sometimes because those institutions are not trustworthy, it degrades over time. And I think that trust can only be rebuilt during peacetime or times in between the crisis. I don't think it's easy to rebuild trust quickly. And so this is something that needs to go on a continuous basis. And honestly, this show that you have here is a great way to get into that, because there needs to be a different level of communication between professional scientists and doctors with community members in a way that is understandable and that is consistent and that's transparent. So I'm really glad to see you have this show.
Thank you. Yeah, no, this has been a great effort. Okay, Jess, I know we're going to run out of time here, and I know there's a lot of questions, but we'll be back this week to answer them. So,
okay, yeah. So if you've asked a question, I'm sifting through these. You're going to be here tomorrow, right, Dr. Stites?
Yes, ma'am.
Okay, so I'll hold some of those for you and Dr. Hawkinson, but just let me squeak a couple more in here. And Kim has a question she thinks is off topic. I think it's a great question because we talk about all these scientists and all these smart people. She said, why can't we find a cure for cancer then? Can you answer that in a hot minute?
Yeah, there you go. Okay.
Well, I mean, cancer's many diseases, and we are curing many. There's not a single answer, and we come to work every day around the world to try to meet that challenge. So, we are working hard on that. I don't think there's any doubt that that through the National the Cancer Institute and the National Cancer Act, I think was 50 years ago, we have made a lot of progress. But that challenge is
so
out
real.
there.
Yeah.
Gauntlet's thrown down.
All right, Sean wants to know, is there a difference between the Pfizer mRNA vaccine and the Moderna mRNA vaccine?
Great question.
Yeah, it is. Dr. Graham?
Yes, there's many similarities. They're almost identical vaccines. They both use the same protein sequence that came out of our lab. They both use a modified nucleotide that came out of the laboratories of Drew Weissman and Caitlin Carrico at University of Pennsylvania. They both use the full-length spike, and they both use these lipid nanoparticles, which are 4 different lipids, 4 different fat molecules combined. Now, the chemistry of 2 of those 4 are slightly different. They're in the same category of molecule, but they're slightly different molecules. And there may be differences in the way they purify their RNA at the end of their manufacturing. So there's some very minor differences, but the Pfizer and Moderna vaccines are very, very similar. And that's why I had my major relief back last November 8th or 9th, I guess, when I heard the Pfizer results, because I knew then that the Moderna would also be working.
All right, Jess, one more question.
Okay, one more question, then we'll hold our COVID-specific ones for tomorrow. But last vaccine question. Nancy just needs some clarification. So he says that every time it infects somebody, it has the chance to mutate and grow into something else. Vaccinated people are still getting it. So wouldn't it be safe to say that even if the majority of the population is vaccinated, it's still just going to spread around?
Great question, Dr. Graham. We know that's not quite the answer, though.
No, I'm glad you're asking that question, because every replication cycle that the virus makes, out of its 30,000 nucleotides, a few of them will change. So a few amino acids will change. But in a vaccinated person, the virus grows up to a level about 1,000 times less than in an unvaccinated person, and it sheds for a shorter period of time. And so if you're trying, this is all a risk-benefit calculation. If you're trying to reduce the frequency of the chance for a mutation, it's much less likely in a vaccinated person than in an unvaccinated person, because the virus replicates to a much higher level, goes through many more replication cycles, and it also is shed for a much longer period of time because your immunity doesn't come as quickly. The other thing that happens is that in immunocompromised people with untreated HIV or chemotherapy or transplant patient, they can shed the virus for a long period of time, and they may be people who don't respond very well to the vaccine. So the only way that they can be fully protected is for the people around them to be fully protected. And if the virus gets into people like that and can grow for a very long period of time, it has even more chances to evolve. And so it's really not about the number of people that get infected. It's about the number of virus replication cycles that occur in all those people.
All right. But this has just been the most inspiring program. I can't tell you how much I appreciate hearing from all of our guests. I want to go around and just ask for final thoughts, and I'm going to start with Dr. Simari.
Well, I think the thing.
By the way, you're coming back, right?
Yeah,
like
I'll be
really
back.
soon.
Yeah, I'll be back.
Really soon.
I think the thing that's striking is that the pandemic has presented new questions almost every day, but the answers have not changed.
Yep.
It's public health, public safety, and vaccination.
Yeah. The rules of infection control.
The rules of infection control. So while the questions change, the answers are the same. And I think sometimes we focus on the changing questions when we should continue to focus on the constant answers.
Yeah. Dr. Graham, final thoughts. That was great.
That was a great answer. I don't know if I can beat that, but one of the things I really hope is that all the 7 and 8 year old children and other age children out there who've had their lives so disrupted by this pandemic will see science in a different way and will be inspired by some of the things that they've seen happen over this year, and we'll have a whole new generation of viral immunologists come through and help us be ready for the next pandemic and do it better.
Thank you. And thank you, Dr. Graham, for the millions of lives you have helped save across the world, and for helping make our world a better, safer place, and for continuing to advocate for science in the face of this COVID storm. Hawkeye.
Yeah. Well, just as Rowdy Piper, the wrestler, said, just when you think you have all the answers, the questions change. But as we just heard Dr. Simari say, the answers to these questions are really the same, and it's public health, and it's medicine, and science, and data. So we'd just like to reiterate that. And, hopefully, as Dr. Simari is going to be back, hopefully we get Dr. Graham back, too, and answer these questions. So insightful. And please, people, if you have been listening and watching, please show this show to people that you may know, and really get it out there, and keep the message going.
This has been an incredibly important program, I think. And one of the things I want to just reference is that there are millions of people across our world and across the United States who have not been vaccinated. Millions have. That doesn't mean you're good or bad, but it does mean that we have to try to work together to try and end a pandemic, even despite having different beliefs. What I would ask, if you've not been vaccinated, is to watch and listen to the program and hear Dr. Graham's voice. We're not out here to make money. We're not out here to try and create misinformation or anything. We're here to try and tell you the truth, and so that you and your family can be safe. And ultimately, that's what we want to do. We want to have something more close to the normalcy we once knew. But the way to get there is to trust the science. We want us all to live long and prosper, which is also V for vaccination. Jess, back to you.
You did it before I got a chance to. I know you're always trying to get in your Star Trek reference for the day. So,
Shocker.
Okay, I told you how to work for it today. You did good, so take a look at this.
Omicron. 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 Omicron.
That is the best. Who did that? What brilliance. And they still can. Dr. Graham, how do you say it? Omicron? What's the answer here?
I say Omicron.
Okay, then that's what we are going to say, Jess.
Omicron.
Right there.
Okay.
Omicron. Remember that, Hawkeye. None of this Tamiflu. It's Omicron.
I know, Dr. Stites, you're suggesting that you and I never mispronounce anything.
Never. We never butcher anything.
All right. Again, thanks everyone for being with us, and don't forget you can go back and watch our shows on Facebook and our YouTube channel. And I also just want to remind everybody before we go about our blood supply shortages in our community. They are big, and we're putting out a call to get people to donate. So the Community Blood Center says its supply stands at a 1 to 2 day inventory, so that's well below the ideal 7-day supply. There are 2 ways you can set up an appointment if you're eligible to donate, and almost anyone can donate, by the way. There is some information on your screen. You can call that number or visit www.savealifenow.org. So please, if you can donate, do so. Tomorrow, it is the leading cause of overdoses. We are talking about fentanyl. It is a deadly drug that has taken and ruined so many lives, but there is a new treatment that is helping those trying to get off of it and stay healthy and stay alive and live well. So we're going to hear from one man. We'll hear his story about how it worked for him and how he's doing today. Plus, what's being done to stop this growing epidemic. So also, on another note, we want to see your kids getting vaccinated. So send in your pictures and your videos of your kiddos getting the vaccine. You can head to the medicalnewsnetwork.org. You can email them to us right there or send them on Facebook, and we will show those at the end of our show. Everyone, thank you so much for joining us. Thank you to our panel today. Have a great day. We'll see you tomorrow at 8.
Subscribe to our morning medical update and open mics with Dr. Stites podcasts. Now everywhere podcasts are available.